Well, good morning, everyone. It took me a while to upload that PowerPoint. Not sure why. It looks a little different to me on this, but we're going to go ahead and continue. Hope you all are staying well and doing okay during this time. That's the main point, is to stay well and try to get through the rest of this semester. I love today's lecture because it's on preterm labor. And when we talk about preterm labor, it has a huge impact because it's one of the leading causes of neonatal mortality, and it's the most common reason for antenatal hospitalizations. It has a huge impact on economics because basically a day in the NICU can cost about $3,000. So it has a huge impact on economics, also healthcare, because of the long-term impact some of these preterm babies provide. So we know that it's better if babies are premature, if we weigh the benefits versus the risk on delivery. If at all possible, we try to keep the babies inside mom for better outcomes. This is what we want to prevent. We know that we have life-saving procedures. The NICUs are so amazing. I know a few of you have been in the NICU, and it's amazing what they can do. If you look back even, maybe 50, 60 years ago, if you go back to the 1960s, 1963, John F. Kennedy, who was the President of the United States, him and his wife gave birth to a son while he was in office, which a lot of people don't realize, and his son's name was Patrick. Patrick was born at 34 weeks gestation. It was an emergency for his wife. They actually took the baby from his wife to try to save the baby at a NICU. At that time, they really didn't have anything to prevent immature lungs. And the President of the United States sat by Patrick's side and watched basically his son die. There was nothing they could do for him. And that was in the 1960s. And fast forward now to 2020, a baby that's born at 34 weeks, we don't worry too much about because we have so much technology and medical help for these babies that 34-weekers do very well. In fact, now we're saving babies 23 to 24 weeks gestation. So that's really amazing. But if you go back to that in the 1960s, you could see the fear that it was for women to deliver premature. Anything below, 37 weeks was a risk to them. Somebody who delivered at 34 weeks was extremely worried. And so was the medical community as well. And so back then, they took extreme measures. When I first started nursing, I remember that if anybody came in with contractions, even if cervix was closed or whatever, we put them on bed rest and we put them on home monitoring. If they started to contract, we would give them terbutaline and all kinds of medications to stop the contractions. And what we noticed back then, though, was that some of the population, those people never did dilate, and they ended up having to be induced post-dates. And so what we found was that we needed to identify those patients who are really at risk for preterm labor versus those who are not. And that's what we have now, is we have tools to identify, to predict those who are at an increased risk so we can center in on them, and those that aren't at an increased risk, we can let them go. So a lot has changed back there. But I remember when I first started, there was a lot of fear, and some of the older nurses that I had worked with had talked about the fear of delivering, anything below 36 weeks for fear, because there was nothing they could do to help those babies, especially the little boys. For some reason, little boys' lungs didn't mature as quickly as the little girls' lungs. And so it was very, very, people were very afraid. So we've come a long way since then. And so we're going to look at some of the strategies that we in the medical community, particularly nurses, have done to help these little ones now that we are able to help even at 23 to 24 weeks. Really, science and medicine does perform miracles. So we're going to start with learning some preterm labor terms and some of the negative outcomes, and then the management of preterm labor, and also summarize some of the triage strategies for preterm labor. When we talk about preterm labor, I think we talked about this a little bit before. It's defined as regular contractions accompanied by cervical change between 20 and 37 weeks. Preterm birth is defined as any birth prior to 37 weeks. And then there's the late preterm, and those births occur between 34 and 36 weeks gestation versus the very preterm birth, which occurs really before 32 weeks gestation. And when I talk about the late preterm birth, those are between 34 and 36 weeks, and a lot of those babies do fairly well. But what we've noticed is that sometimes we treat them as term babies, especially when they're close to 36 weeks. And what the medical community realized was by treating them as full-term babies, we realized that we were missing that they were still having troubles with feeding, they were still having troubles with maintaining blood sugars and maintaining heat. So even if they are late preterm, even if they're 36 and 2 days or something like that, we still we keep a close eye on those babies to make sure that they're eating okay, that they're maintaining their temperature and blood sugars, because they're still considered premature, but they usually do very well. When we talk about preterm labor, we know the gestational age is between 20 and 37 weeks. And preterm labor is kind of when we talked about the definition of labor. Preterm labor consists of contractions that are occurring more frequently than every 10 minutes, that are lasting more than an hour. So that would be every 10 minutes, at least an hour or more. Contractions could be painful or painless. But preterm labor, when we speak of it now, it's not only contractions, but it's also the progression of the cervical change. And so we're looking at cervixes that are like 2 centimeters or 80% effaced, but in some cases we're alarmed even if it's less than that. So preterm labor is contractions with some cervical change, contractions at least 10 minutes apart. We talked a little bit about the impact on society. We know that neonatal morbidity and mortality has an immense burden on families, health, and education. If you've ever seen a family that has a baby in the NICU, it's an extreme burden, especially if they have other children at home. They have a hard time getting in to see the babies. And if we think about even today now with this COVID virus going on, a lot of moms aren't even allowed to see the babies and such. So having a baby in the hospital is hard enough. Plus the unknown: is my baby going to be okay? Is it going to have lifelong problems? Those types of things. An extreme burden on families. And also health and education, because some of these babies, even though they do survive, they may have long-term disabilities, and also involving social services too. Economics has a huge impact on hospitals and society, with the daily cost of a day in NICU is well over $3,000 a day. And I think your PowerPoint said $1,000, but it's actually up to about $3,000 a day. Prolonging pregnancy may even reduce hospital costs. So we know that it's best to keep babies in, not only for their own well-being, but also for economics as well. Again, preterm birth is the leading cause of neonatal mortality, and it's the most common reasons for antenatal hospitalization. So a lot of times if you go into the antenatal departments or even the labor and delivery departments, you are going to see moms there who are there, and we're watching them for preterm labor. Our goal really is early identification for those who require attention as well as those who do not. So triage is really important for this factor. When patients come into triage and they're preterm and they are contracting, we have to have tools to identify those we really need to watch closely versus those who not. The correct identification of preterm labor is key for positive neonatal outcomes. We don't want to put somebody in the hospital who really doesn't need to be there and put all kinds of stressors on there, but we definitely want to identify those who are at high risk for preterm birth. This may prevent costly and stressful interventions for women who are either not experiencing true preterm labor or unlikely to deliver in the near future. We don't want to put them through the stressful interventions, but at the same time, we want to identify those with threatened preterm birth And we do know that when we talk about people who show up in with contractions, and that really less than half will go on to deliver prematurely. So triaging women with preterm labor is vital to positive outcomes. We know there's many complications on preterm for the newborn. There's respiratory distress syndrome, there's neurological development impairments, and some of these are lifelong. So we know it's best to keep baby in as long as possible. Again, we always weigh the benefits versus the risk for both mom and baby. The March of Dimes actually started out fighting against polio, and when polio actually was resolved, and they kind of switched their focus to premature babies and helping those. They've done a lot of work. They've done a lot of studies on helping us conquer premature birth, and they continue on their fight by doing lots of studies. In fact, some of their studies helped prevent inducing early, whereas now we only induce those that are 39 weeks or above, unless it's medically indicated. So March of Dimes really does a lot for the fight to fight premature birth. When we talk about risk factors, which women are we going to flag? Which one are we going to put the red flag over? Say, okay, these ones I'm going to watch really, really closely. Well, we know that 50% of women who deliver preterm have no risk factors, none at all. So we have to watch everybody really close. But we do know the 3 most common risk factors. If somebody has had a preterm baby before, I'm going to be watching them very, very closely, because chances are they're going to do it again. So any history of preterm birth puts these people at a huge risk for doing it again. And we also know that those with twins or triplets, any multiple gestation, they're more likely to deliver early. And also those with uterine or cervical abnormalities. Sometimes the uterus is shaped like a heart, and sometimes it has a septum that actually divides the uterus. And sometimes that uterus even has 2 cervical openings that are kind of like 2 separate cervixes, which makes it a perfect Gray's Anatomy show when somebody gets pregnant with one guy's baby on one half of the uterus, and then the other half somebody else's. In fact, there was a Gray's Anatomy, a show on that. But if they've only got half the space to grow in, then once they run out of space, they're probably going to go into preterm labor. So we have those uterine abnormalities. Cervical abnormalities, we know that HPV is on the rise, and a lot of times they're freezing the cervix or taking a piece of the cervix, which causes cervical incompetency, meaning the cervix does not remain closed but begins to open up, where then we have losses. So we do know that the 3 most common risk factors for our patients are, if they've done it before, multiple gestation, and uterine and cervical abnormalities. Again, we have to pay attention to all women, because 50% have no risk factors. So what are some other risk factors? Well, we already talked about a previous preterm birth, a multifetal gestation, twins, triplets. The more you have in there, the greater your risks are. Uterine or cervical abnormalities. Any kind of infection. We're talking about UTIs, STIs. Any kind of infection causes the uterus to be irritable and can cause preterm labor. That's why in prenatal care, we check them almost every visit for UTIs. We check them routinely for STIs. We look at their history of habits, and maybe we'll check them more frequently. But we know infections, even they say some dental infections, abscesses, can cause preterm labor. So we need to pay attention to any kind of infection. Any kind of second trimester bleeding, in vitro fertilization, those patients are at risk. Whether they're underweight or overweight can cause a problem. And we also know that high blood pressure and preeclampsia is a definite risk factor, because we may have to deliver those babies early due to the benefits versus the risks. Those are the medical risk factors. If we look at the lifestyle, Anybody who does late or no prenatal care is at an increased risk because we didn't get a chance to look at risk factors. We didn't get a chance to look at the STIs or the UTIs. Anyone who smokes, any substance abuse, domestic violence, sexual abuse, lack of social support, and stress are lifestyle risk factors. So what are the symptoms of preterm labor? Well, we tell women if they start to contract about every 10 minutes, they need to lie down, drink some fluids, and see what happens. If it continues after an hour, they should contact their healthcare provider. So we look for anybody who's contracting about 10 minutes or more. If there's any change in vaginal discharge, if they're leaking fluid, it could be premature rupture of membranes. Even an increased vaginal discharge could mean that things are softening or something's happening down there. Vaginal bleeding, sometimes just a low, dull backache that's consistent with like menstrual cramping can be a sign for some women. And abdominal cramps with or without diarrhea. And remember, diarrhea sometimes causes irritability to the uterus and causes cramping, and dehydration causes cramping as well. So dehydration is a key factor in Arizona because when women if they go out like to the Renaissance Festival and it's 90 degrees out and they drink maybe one small bottle of water, it's not enough and they may start cramping. When they come in to triage, we just hydrate them and the contractions go away. And that's what happens with diarrhea. Not only does it make the bowels make the uterus irritable, but dehydration sets in as well. Monisha Dimes and other people are still trying to study what causes preterm labor. Well, they're numerous and they're complex, and there's a series of complex interactions. But we do know that some of the causes are uterine distension due to polyhydramnios, due to multiple fetuses, infection, which we already talked about, even periodontal infections, bleeding, sometimes with placental previa, abruption, and other sources. And sociodemographic factors like poverty, lack of support, and stress. We do know that continued research is needed because it's a very complex problem. And remember I told you that one of the biggest things is predict those who are at risk, because we want to identify those who are more prone for preterm labor and make sure we watch them or treat them, whereas at the same time, we don't want to put added stress on those who probably aren't going to deliver early. So we have 3 of the most influential factors in the prediction of preterm labor. One of those is history. If they've had a prior spontaneous preterm birth, they are at high risk. So we're already going to be thinking, Another one is what we call a fetal fibronectin test, a lot of times referred to as FFN. This is a wonderful test, but what's interesting is really it's like we're looking at those who are positive, and we're thinking, a negative is reassuring. A positive doesn't necessarily mean they're going into preterm labor, but it's something to make us look more closely at those patients. So what is a fetal fibronectin test? What it is, it's just a swab. We take the swab and we actually swab the inside of the vagina near the cervical vaginal area, and we send it to lab. In about 40 minutes, the lab's going to come back with a result, and it's either going to be positive for fetal fibronectin, the proteins, or it's going to be negative. And what happens is with this test is you've got the uterine wall and you've got your bag of waters, and there's a glue-like substance between the two that is there, and it stays there. And about 2 weeks before somebody goes into labor, that glue-like substance kind of dissolves and you can find it in the cervical vaginal area. So if the test comes back positive, we're thinking, these people might deliver in the next 2 weeks, not necessarily saying they will, but they're at a higher risk for. What we're really looking for in this test is a negative because it's reassuring, but it's a very good test. Now, if you perform this test, you need to ask the person you're giving it to is if they've had anything in their vaginal area in the last 24 hours. And of course, for most of the women, it's going to be have they had sexual intercourse. If they have, you need to wait 24 hours before you can perform this test. Otherwise, you may not get an accurate reading. Other things that could be a vaginal ultrasound or a vaginal check in the doctor's office as well. So you need to make sure that there's nothing's been in the vagina in the past 24 hours. If there has been, from the time something went in, you have to wait 24 hours to do the swab and to get the results. Again, a negative is reassuring that they probably won't go into premature labor, and a positive is something, let's look at all the factors. A cervical length is when we send them to ultrasound and they put a probe into the vaginal area, and they can actually measure the length of a cervix. And we know that 25 millimeters is a good length, but it also depends on where they're at in the pregnancy. So if their cervical length comes back short, like maybe 15, then we're like thinking, that cervix is shortening. After we perform the fetal fibronectin and probably the cervical length, a lot of times we will do a vaginal exam to see if their cervix is actually dilating and what the effacement is of that cervix as well. If they are dilating, or if the cervix is effacing and beginning to dilate, then those are pretty good predictors that this patient, we need to watch and maybe treat. So let's say somebody comes in who's been contracting about every 10 minutes for the past 2 hours, a history of preterm birth, hasn't had any sexual intercourse in the past 24 hours. We do a fetal fibronectin. It comes back positive. We do the cervical length, and it comes and shows us that the cervical length is short. I guarantee you we're going to probably watch that patient in the hospital and possibly treat. So the fetal fibronectin is a diagnostic test, as we spoke of, for preterm labor. FFN is a glycoprotein glue found in plasma, and it's produced during the fetal life, and it normally appears in the cervical and vaginal secretions early and late pregnancy. So we're looking at the late pregnancy one. So anywhere between 24 and 30 weeks gestation, if we need to test, we will do the swab test. Again, it doesn't it predicts who will not go into preterm labor. So we're looking for a negative to be reassuring. Preterm labor is unlikely to occur with a negative result. Now, just because they're positive doesn't mean they're going to go in, but we're going to be looking at them very closely. Again, they have had to have had no cervical intercourse or cervical length or vag exam within 24 hours of testing. The cervical length, which we discussed earlier, is a transvaginal ultrasound to measure the length of the cervix. Normal is about 20 millimeters with a strong positive predictive value. Now, some hospitals will go with centimeters, and that would be 2.0. So don't get confused with that. How short is too short for the cervical length? Well, a cervical length of less than 15 millimeters at 22 to 24 weeks gestation is very abnormal, and it's associated with a significant risk of preterm birth. So usually we're going to be looking for a normal of greater than 20. The cervical length can also determine if there's funneling of the membranes into the cervical canal. And that just means that because the cervix is opening, the bag of waters is coming into the cervical canal, which puts the patient at risk. It can also see if the cervix is dilated and a location of a cervical suture present. And we'll talk a little bit about a cerclage later on. Again, history is really important because the obstetric history helps identify patients who need to be monitored closely, as well as prophylactic therapy. So the FFN and the cervical length are particularly useful for determining which patients do not require intervention, but we also look at the history. So when we're assessing somebody for preterm labor, we're also looking at the cervical exam. Sometimes we need to do that Fern test or an Amnisure test to see if their bag of waters has been broken. Remember, ROM stands for rupture of membrane. When we do the sterile speculum exam, that would be the Fern test where we're looking under the microscope. Also, if a patient comes in contracting, I can guarantee you we're probably going to screen her for a urinary tract infection by sending off a UA, and we're going to be looking at other infections as well. All patients who come in, of course, we're going to assess to make sure baby's doing okay, and we're going to monitor uterine activity. So how do we manage those now at risk for preterm birth? Of course, we already know that we as nurses work on prevention, early recognition, and then we need to predict the risk, diagnose, and then we have our interventions for those who are at risk. Management includes health promotion, disease prevention. So basically, we instruct our patients to stay hydrated, to keep on with their prenatal care, and to treat any infection that comes up and make sure it goes away. Particularly UTIs our women are prone for. And STIs, we need to treat those as well. So again, if they go to prenatal care, we're going to be treating infections. We're going to be dealing with disease prevention. It's also health promotion. And again, educate on the importance of hydration, particularly in Arizona. We also, education is extremely crucial. We want patients to be aware of symptoms so that we can get it early. So we educate our patients. If they are contracting, if they feel like they have those, like that low backache where they're going to get menstrual cramps, increased cervical discharge, or if their bag of waters is broken, they need to seek help by their healthcare provider. And then we need to predict the risk, okay, which leads to appropriate management. Because remember, we don't want to put those through stressful interventions that don't need it, but we want to make sure we capture those who are at high risk. So we need to identify those who require intervention and identify those who do not require intervention. So the degree of intervention is dependent on predicting the risk. And again, that was through their history, through FFN, cervical length, vaginal exams, infections, which would be WBC, UAs. Triaging preterm labor is vital to proper intervention. Management, well, we focus on delaying delivery at least for 48 to 72 hours, and that is crucial. Those 2 to 3 days that we can delay delivery is crucial to those babies, because we can actually give mom steroids to facilitate fetal lung maturity. So if we can hold off delivery for a couple of days, we can actually give them steroids. In addition to that, if we give them magnesium sulfate for a couple of days, it actually produces neuroprotection for those infants. So the infants, even though they're born premature, have better outcomes. So when we talk about management, sometimes if somebody's coming in with a little bit of cramping, but their FFN maybe is negative and their cervix isn't dilated, sometimes we'll just tell them to take it easy. Maybe restriction of sexual activity, which can cause cramping for some individuals. Modified bed rest. Now, when I say, if I'm going to send somebody home and say bed rest, you know that basically means kitchen and bathroom activities, because they're going to be up and walking around, but we don't want them going to parties or going to grocery shopping or anything. We just have them monitor, see if they're contracting at home, and to seek help if they continue to contract. We ask them to manage their stress, to utilize social support. But we know that when we talk about preterm labor, we talk a lot about all our interventions and everything, but don't forget how the patient might feel, the physical, fear, psychosocial support system. I mean, they're afraid of the unknown. And most of the time, they're going to do their best to stop those contractions when they're at home, but they're very fearful. This is what we want to prevent. Some people ask why the baby is in the baggie, and that is to keep the heat. Babies that are born premature have a hard time regulating heat or regulating their temperature. Sometimes, though, that, we need to give medication. So maybe a patient is cramping a little bit. We can always start off with some ibuprofen or Indocin or Toradol. I'd say the more if they're at a high risk and already dilating and everything, we're going to be a little bit more aggressive. So let's talk a little bit about tocolytics, or the drugs that we use to manage preterm labor. Now, ibuprofen actually blocks the production, and it's Motrin, Advil. It blocks the production of prostaglandin, which slows or stops the contractions. And we know this works because a lot of women will use it for menstrual cramps. So usually we can give about 600 milligrams every 6 to 8 hours. But the thing is that if the patient is at least 32 weeks, we probably will not give ibuprofen. And sometimes doctors are hesitant even prior to 32 weeks because we know that it can decrease amniotic fluid. So very rarely is it given to patients after 32 weeks. But it can be very beneficial to those patients early in pregnancy that are cramping and can stay at home. If it is given after 32 weeks, which normally in most cases it will not, we need to monitor the amniotic fluid with the ultrasound called an amniotic fluid index, which is basically an ultrasound that looks for pockets of fluid and can measure the amount to make sure that is maintaining a good level. Indocin is kind of the same way as the ibuprofen. It keeps the body from making prostaglandins or substances which cause uterine contraction. It works mainly the same way that ibuprofen does, and it also has some of the same risk factors. So it kind of just depends on where the doctor did his training or what his preferences are if he chooses Indocin versus ibuprofen. Again, it may cause some indigestion in women. They need to take with food or antacid, same as the ibuprofen. And it also has some serious side effects regarding the amniotic fluid and also the fetus producing and changing the way the blood circulates. So again, these medications, it's always the risk versus the benefit. And most of the time they're used in the early part of pregnancy prior to 32 weeks. What's nice about those is that they can stay home and manage their cramping. Usually it's for cramping type contractions. Now, Toradol we know is like the Mega Motrin. We can give it IM or we can give it IV, single dose, or we can give 300 milligrams, multiple doses. It's non-steroidal and it's an anti-inflammatory, so it works fairly well. Nifedipine or Procardia, you may have learned about when you did your pharmacology, but it's a pill. We give it PO, which is nice. It's a calcium channel blocker, and we know that if it's a calcium channel blocker, the muscles need calcium to contract. So if we block the amount of calcium going, that the uterus is going to stop contracting. So it works fairly well. It relaxes smooth muscle. The thing, though, is we also give it for hypertension, so we know that it may cause some hypotension. So we watch for hypotension. This may not be the drug of choice for those patients that have a low blood pressure, but it works fairly well and it has very little side effects other for the hypotension. And again, it's PO, and so sometimes we can send patients home with the nifedipine. Terbutaline is a drug that we used to use a lot when I first started working, and now we're not using it as much. Basically, if they come into triage and they're contracting, it works really well to stop those contractions right away. And so you still will see it being used. So a lot of times a patient comes in contracting and she's starting to dilate and we want to stop those contractions right away. We'll give the patient 0.25 milligrams sub-Q every 30 minutes times 3 to relax the uterus. Back in the day, we used to discharge them home with PO medication, but we no longer do that because the benefits haven't outweighed the risks. Because when a patient takes terbutaline, the side effects causes them to be nervous or tremorous, a little bit tachycardia. They get palpitations. It's almost like drinking too much coffee. And it's really hard on those, particularly those that have some anxiety and panic disorders. It can cause them to really freak out a little bit. So we limit the use of it, mainly for hospital use, to stop those contractions really fast. We know that it causes tachycardia, so it's really important that you know the nursing intervention prior to giving terbutaline in the clinical setting. So basically, you would need to take your patient's pulse and make sure that it's less than 100 beats per minute prior to the administration of the med. Can you imagine if you gave it to somebody who had already a pulse rate of 120 and then you gave it and their pulse now is greater than 120? So again, it can cause some tachycardia. Again, that tachycardia causes some panic on some patients. So if we use that needs to be used with caution, but we still use it because it's a really good drug to stop those contractions right away, like before we have an IV too. And then there's magnesium sulfate. And that's what we see. Those patients that are going to stay in the hospital are probably going to be high risk and need the magnesium sulfate. So if we triage them, and they maybe have a history, they have a positive FFN, and their cervix is already now 2 centimeters. We're like going, whoa. Usually we will admit them. You can admit them either to antepartum or labor and delivery. Some people have a specific antepartum unit. That would be fine to put them there, but if they are unstable, they're probably going to send them to labor and delivery. You can send them to labor and delivery, and once they become stable, they can go to antepartum units. Some hospitals really don't have a specific antepartum unit, so it depends on the facility. But if they're going to be admitted, they're going to get an IV main line of lactated ringers, and we are probably going to start magnesium sulfate separately in IV piggyback. Excuse me. Magnesium sulfate, again, is a calcium channel blocker, which if the muscle does not get calcium, it relaxes the smooth muscle. So it slows contractions down, and it really is effective and works. It also works as a neuroprotection for the baby's brain as well. The latest studies in the past 10 years have found. So it kind of has a double benefit. So even if a patient, we put them on for a couple of days, well, it will benefit the infant. So how do we give magnesium sulfate? We give it IV piggyback. The infusion pump is needed. A loading dose of this is going to be 6 grams, so we're a little bit more aggressive, the loading dose and the maintenance dose with preterm labor versus what we use for preeclampsia. Again, it's a high-risk medication. It requires 2 RNs. The side effects that patients feel is whenever you give the bolus, they get really, really hot. They get sweaty. Sometimes it burns at the IV site. Sometimes it causes nausea and vomiting and muscle weaknesses. And I always say this, if you're going to tell the patient that this is going to happen, then you say, this is what we're going to do about it. You might get a little hot, so we're going to fan you off. We're going to cool your room down. We're going to take off these blankets. If you begin burning at the IV site, I'm going to put a little bit of ice there. I can give you some Zofran for the nausea and vomiting. Sometimes we use that prophylactically. And we usually, when we give that loading dose, the RN will stay with the patient during the loading dose. Again, nursing interventions for the magnesium sulfate. Educate your patient on the drug, the purpose of it, and how they're going to feel with it. Again, we can apply ice to the IV site, cool wash rags in a cool room, antiemetics available. Always make sure you have a Zofran dose on board, and most of the time you will. Whenever you give magnesium sulfate, is so important, and this is both for preterm labor and if you're giving it for preeclampsia. You need to constantly assess respiration status because remember, when you put somebody on magnesium sulfate, it's relaxing the muscles, and so sometimes those respirations start going down to 12 and below. Check your respiratory status. We need to check the deep tendon reflexes, which is kind of hard to demonstrate on here. I'll talk a little bit about that. Remind me to when we meet as a class, but we just tap their knee and we check their tendons, reflexes. If there's a change in level of consciousness, or if their urine output is less than 30 cc's an hour, we definitely have a problem. You would stop the magnesium sulfate first, contact the healthcare provider, but the antidote to magnesium sulfate is calcium gluconate. And another important drug that we use to manage preterm labor is steroids. Okay, antenatal glucocorticoids reduce the incidence of respiratory distress syndrome on the infants. So this drug is given to mom when we predict that she may deliver early. We give that prophylactically for baby. We can give it anywhere between 24 and 34 weeks gestation, most commonly known as betamethasone in our hospitals. Betamethasone is most commonly used steroid. How we give it is we give 2 injections of 12 milligrams IM 24 hours apart. So if they come in and they have a positive FFN, their cervix is dilating, the cervical length is short, guaranteed, one of the first things you're going to do is give mom a shot of betamethasone, because you need to give her one shot, 12 milligrams IM, and then 24 hours later, give her the next shot. And 24 hours after that next shot, they've gotten the full benefits of the betamethasone. They're in the window. Now, even though you don't get to that 24 hours after the second dose, I can guarantee you, even that first dose, whatever can get to the baby is going to be beneficial. What it does, it helps mature the baby's lungs. Dexamethasone is sometimes used instead of betamethasone. I, in the clinical setting, have never used dexamethasone, but it's 4 doses of 6 milligrams, 12 hours apart. Again, most of the hospitals in Arizona, you're going to see betamethasone as the steroid that is given. Don't worry about the single rescue dose. I'm not going to get that specific. But if you've already had a patient, maybe at 24 weeks, that received 2 doses, and then they come back 10 weeks later, sometimes we'll give them a rescue dose. But that's more than what you need to know. So these steroids. We know that steroids are contraindicated in women with systemic infections, and you should already know that by med-surg and your pharmacology days. So it's contraindicated in any woman with a systemic infection. Also, we know that women who are on medication for gestational diabetes or pre-gestational diabetes are at risk for significant hyperglycemia. Now, we know we always weigh the benefits versus the risks. And even though they are diabetic and on medications, if we look at the risks versus the benefit, it's probably going to benefit our patients if we give them the steroids and watch and monitor their glucose and give them extra insulin or medication to handle the hyperglycemia. So the important thing there is to monitor the blood sugars. Hypertension may worsen also with the steroids. So again, we have to always weigh the benefits versus the risks. But just be aware that you can, hypertension can worsen, diabetes, they'll get hyperglycemia, and it is contraindicated in women with systemic infection. Management also includes progesterone. They have found that, remember we talked about how progesterone maintains the pregnancy. It keeps the uterus from contracting and everything else. And what they have found that some people have low progesterone levels. So if patients sometimes have a history of SABs, which stands for spontaneous abortions, like miscarriages, sometimes we'll prophylactically give them progesterone up to 12 weeks gestation. Sometimes we'll even continue these progesterone injections or daily vaginal suppositories, continue them on up to 16 to 34 weeks. There's a lot of a lot of current studies going on how to manage preterm labor with progesterone. But what they're finding is it's extremely beneficial to those women who have cervical incompetency, or those that have a history of frequent SABs due to low progesterone levels. So for cervical changes shown prior to 20 weeks, progesterone is now being used and quite beneficial. Again, sometimes it's used further on in the pregnancy as well. Another huge cause for preterm labor is cervical incompetence. And we talked about sometimes the cervix just does not want to hold. It doesn't stay closed, thick and long for the entire pregnancy. It starts to open up. And there's different reasons for that. But one of the things that we're seeing mostly is the increased HPV or things that have been done to the cervix. Some people just have an incompetent cervix where it just doesn't maintain closed. It doesn't stay closed. So what they do is anybody who's had like a spontaneous abortion or a miscarriage, history of them, they can identify those who have a weak cervix or an incompetent cervix. And prophylactically, what they'll do for these patients is anywhere between, they can say 12 and 14 weeks, 11 and 14 weeks, but early on, what they do is they put a stitch in the cervix to keep it closed, and this is called a cerclage. It's rarely used after 24 weeks. It's mainly used as prophylactic between 11 and 14 weeks, or as your slide says, 12 and 14 weeks, but basically before 12 weeks. What these patients do is they're sent to triage, and we usually give them a regional anesthesia like an epidural block, and they go in. It's a very quick procedure where they put a stitch in the cervix. We watch them, we recover them, and we can send them home. Then about when they're term, which is about 37 weeks, the doctor in the office can remove that stitch and then let them go into labor on their own. It's been very beneficial. Again, it's not used to rescue if somebody comes in and their cervix is opening at 24 weeks. It's not used for that. It's used prophylactically for women with a history of cervical incompetence. They go in and put the stitch. That stitch is called a cerclage. Remember what we talk a lot about the management and everything else, but again, don't forget about the psychosocial effects on mom. When a mom is put in the hospital and put on magnesium sulfate and the threatened premature birth, not sure if her baby's going to be in the NICU and if it's going to survive or have long-term, health problems, she feels a sense of loss of control. She has anxiety. She might even be angry. She may experience depression and guilt. Boredom, loneliness, mood swings, and stress. Also, her support system gets stressed out. Sometimes if the mom's the breadwinner, now the husband has to figure out a way, there may be a loss of income, increased responsibilities on their support systems, financial strain, fear, anxiety, and a total disruption of family routine. Currently, there's a lot of research being done on preterm labor. We do know that African American women are more prone for preterm birth, and we're trying to find out why. We're trying to look at more of the causes, so maybe we can do more prevention. There's a lot of studies being done on the use of progesterone for preterm birth, and also the use of terbutaline, and those studies are showing us that we use it less often because of the side effects of palpitations, anxiety, and those types of things. Again, triaging women with preterm labor is of utmost importance. We have to look at the history, the risk factors. Remember the risk factors: previous preterm birth, infections, those types of things. We look for the clinical evaluations of signs of true labor, which are contractions at least 10 minutes apart that are actually doing something to the cervix. We look to see if they need a fetal fibronectin, cervical length, a urinalysis, and evaluation of infection, which could be a WBC. There are some hospitals that don't have a level 3 NICU. So some hospitals in rural areas, if somebody comes in and they're in preterm labor at 27 weeks, they will evaluate the risk. But a lot of times what they'll do is transport that patient while they're pregnant to a facility that has a level 3 NICU so that in case she delivers, they have the best NICU available for that baby. A completion of a course of the steroids is really important, the tocolytic agents if needed, and prophylactic antibiotics should be considered if GBS is a possible concern. Every baby is worth the wait. So as you go through this PowerPoint, do some of your readings or whatever, write down any questions that you have, and I'll probably cover preterm birth a little bit more, maybe with a case study or something on Thursday to make sure that you understand all the concepts. But write down any questions that you may have, and I'll try to answer them during class time. So you guys have a great day, and we'll all talk on class time on Wednesday.